Dear judges, ladies and gentlemen, good afternoon. I'm Zhang from Naval Medical University. The topic I'd like to share is the establishment of the score-fit risk stratification model for early-onset colorectal neoplasia, evidence from a nationwide prospective study. Colorectal cancer has become the most common gastrointestinal malignancy in China, with a prevalence of nearly 10 million in 2011 and the incidence of 4 million in 2016. While the occurrence of late-onset CRC is lowering through colorectal cancer screening, incidence of early-onset colorectal cancer is increasing and projected to become the leading cause of cancer-related deaths among young individuals. Facing the dilemma of increasing early-onset colorectal cancer and limited colonoscopy capacity, guidelines recommended to lower the starting age of colorectal cancer from 50 to 45 years old. But it was not suitable for screening of early-onset colorectal cancer because of the varied individual risk. Our previous work, the National Colorectal Polyp Care Program, constructed a newly risk stratification model for colorectal neoplasia in Chinese population and reached good performance, which was published on the Journal of Hepatology and Oncology in 2022. However, previous related studies toward early-onset colorectal cancer was either case control studies or meta-analyses. So a feasible and effective risk stratification tool is lacked but warranted for early-onset colorectal cancer. So our aim is to investigate potential risk factors, develop and validate a risk stratification model, and provide a pragmatic screening strategy for young adult population. NCPC was a prospective multi-center study implemented in 175 hospitals of China. Our study was a secondary analysis with NCPC data, including individuals aged between 18 to 49 years old. We excluded suspected or confirmed colorectal cancers or other malignancies, inflammatory bowel disease, intestinal obstruction, and other disease. The primary outcome was colorectal neoplasia, included CRC and all the precancerous lesions of CRC, including adenoma, SSL, traditional serrated adenoma, and hypoplastic polyps. The secondary outcome is CRC and advanced colorectal neoplasia, ACN, including CRC, advanced adenoma, visceral adenoma, advanced SSL, and TSA. Eligible participants were included to complete the questionnaire to find the risk factors associated with lifestyle and environment, and also undergo fecal immunological test, a widely used non-invasive method to detect CRN, and also colonoscopies. It is the gold standard for CRN diagnosis. A total of 4,661 participants were included and randomized into the derivation and validation cohorts, which exhibited comparable demographic and clinical characteristics. Based on the derivation cohort, 7 risk factors were identified to be independently increased with increased risk of early-onset colorectal neoplasia, which were all included in the development of our risk stratification system, which score assigned to each factor. The risk of colorectal neoplasia increased with the score, and our risk stratification system showed good discrimination in both derivation and validation cohorts. The increased score was then divided into 3 levels, representing participants under different levels of risk. As we described previously, the fecal immunological test, FIT, can contribute to the detection of CRN in a widely used and non-invasive way. So we tested if the application of FIT and the combination of increased score can improve the detection of CRN. Compared with the FIT-negative participants, FIT-positive patients showed higher risk for CRN, advanced colorectal neoplasia, and colorectal cancer in low and middle risk groups. Compared with the increased score only, the score-fit model further improved the discrimination ability of the model for CRN, SAN, and CRC. Furthermore, using the bootstrap method, we found that the score was well calibrated in both the derivation and validation cohorts, and also internal validation. And both cohorts showed high specificity, indicating the risk stratification model in the current study showed good generability and also high specificity. We then test if the ECRI score and the combination with FIT can be used in our validation cohorts. Using the ECRI score, we successfully classified people into low, medium, and high risk, and the incidence of CRN increased with the level of the risk. We can see in higher risk groups, the incidence of CRN is almost 30%. It was the same as the validation cohorts. By integrating with the FIT, the model optimized the distribution, showed higher detection rate of CRN. And also, higher risk groups show significantly higher prevalence of colorectal neoplasia and advanced colorectal neoplasia. Finally, we identified independent risk factors for early onset advanced colorectal neoplasia and also CRC. We found age, smoking, diabetes, and hematochezia were independent risk factors for early onset colorectal neoplasia. All these variables were also identified as independent risk factors for early onset CRN and has been included in our ECRI score. And for early onset CRC, hematochezia and anemia were two independent risk factors. In conclusion, we are the first to develop and validate a risk stratification model involving a combination of lifestyle environment risk factors as well as alarming symptoms based on a nationwide prospective study, showed good risk stratifying ability for early onset CRN and might shed some light on individualized cancer screening. That's all. Thank you for your listening.
Such an interesting topic. Do you have any comments or any questions?
What is the another risk factor in the future you should be to study for the improve of the risk score?
So another method to improve the detection of early onset colorectal cancer? Yes, thank you. Actually, there are no other current studies recommended to use a colonoscopy, but in all of the countries, especially non-Western countries, the colonoscopy capacity is limited. So it was impossible to use the gold standard to screening for early onset colorectal cancer. And we recommended to use both the combination of lifestyle environmental risk factors, as well as the molecular pathway, just as the fecal immunotest and other molecular pathway, just as MSDT2, our another manuscript published in gastroenterology in this year with an impact factor of 25. Yes.
Let me admire your work because it's a very large data and you have done a very good job. Can you translate your finding to lay person? How would you recommend them to modify their behavior?
Thank you for your question. Yes, we have recommended it to a lot of hospitals in China. Actually, we recommended the participants with colonoscopy findings during their physician and people are under higher scores of our ECRI score. They are under higher risk. And for people who have positive findings of fecal immunological test, all the three young adults, we recommended them to have a colonoscopy to find the correct findings. Yes, thank you.
About the behaviors?
In where?
The behavior,
like changing lifestyle or...
I know. If young adults with hematochezia, anemia, and other, we call that their alarming symptoms, they will be at higher risks of early onset colorectal cancer. And for participants with family histories of colorectal cancer, and also for diabetes, smoking, and more older age, just as 45 to 49 years old, we recommended these participants, if they are under the higher risk, to do colonoscopy to find if they have colorectal cancer.
Thank you very much.
Thank you.